Good evening. Welcome, everybody. Thank you for joining us this evening for our webinar, an EdgePRO experience utilizing advanced cleaning and disinfection technology in everyday practice with Dr. Bradley Ross. Before I introduce Dr. Ross, just want to say thank you for joining us this evening. My name is Chris Rabbit, Vice President General Manager here at Edge Endo. For those of you that are Edge customers, we thank you for your business. For those of you that are interested in EdgePRO, we look forward to providing an informative discussion tonight with Dr. Ross. Dr. Ross has been an adopter of the technology since we launched EdgePRO in the early 2022 timeframe, really at AAE in Phoenix, and has gone really all in with advanced cleaning and disinfection, utilizing this technology every day, day in, day out, he and his associates. So we're really happy to have him here. Dr. Ross hails from Colorado Springs. He did his doctorate in dental medicine from Southern Illinois University School of Dental Medicine, completed that in 2003. While on active duty, he completed a one-year advanced education in general dentistry residency with the U.S. Navy at Naval Station Great Lakes in 2004. Stationed with the U.S. Marines in Miramar, California, and deployed to Fallujah, Iraq as the clinical director in support of Operation Iraqi Freedom. Dr. Ross received specialty training and a Master of Science in Health Sciences from the National Naval Medical Center in Bethesda, Maryland. After being recognized as the Navy's top dental resident with the Chief of the Dental Course Award, Dr. Ross finished his Navy career in Newport, Rhode Island, where he served as the endodontic specialty advisor for the Naval Health Clinic in New England. From there, he and his wife, Karen, with their two daughters, Alexandra and Garrett, relocated to Colorado Springs, and that was in 2012, where he's been in private practice since, enjoying the lovely outdoor active lifestyle of Colorado Springs, and really, in addition to a thriving professional career as an endodontist, enjoys hiking and skiing, is also an avid fan of the Broncos. So we'll see how that's working out for him this year. But
not well.
We're really happy to have you here, Dr. Ross. I'm going to, before I pass it over to you, just one housekeeping item. For those of you online here, you'll see on the right-hand screen of your panel there's an opportunity. If you go down and see where there's questions, you can tap that segment there, and it opens up a bar. You can ask any and all questions. As you do that, I will be able to collate those questions, and what we'll do at the end of Dr. Ross' presentation, we'll be able to ask those questions and have some good dialogue. So please ask away. We'll look forward to getting any and all of those questions answered. Again, thank you for attending, and I'd like to now pass it over to Dr. Ross. Thanks.
Thank you, Chris. So yeah, I'd like to thank Edge for giving me this opportunity to kind of share my story with everybody. And I guess we can just jump right into this. So I'm gonna kind of break this up into three parts tonight. I'm gonna talk to you first about my story, kind of why we got the Edge, what our motivations were, how we're utilizing it. Then kind of give you the protocol that I personally have settled on, and then show you a few of the trophy cases, that I've done that I really enjoy and really rely on the Edge anymore to achieve. So, so without further ado, to help you understand my story, you kind of have to go all the way back to 1998 when I was shadowing my hometown dentist, Dr. Michael Geary. And at the end of my time with him, he took me into his office and he said something that I'll never forget. He said, "Brad, if you have one takeaway from our time together, I want you to remember this. You don't have to be the first dentist on the block with a new toy." And then he proceeded to show me his closet. He called it his closet of shame, with his gadgets that he'd accumulated over the years that he had just known would change his practice. He'd utilized a couple of times and, moved on, basically. And that stuck with me through all my years of dental school, my AGD, my Navy duty stations, and my residency. And finally here in Colorado Springs, when the first wave of electronic irrigation systems reached the market. And while their marketing techniques were anything but gentle, their costs, their time per patient, the logistics of my multi-partner, multi-location endodontic practice just gave me pause. It just didn't seem like a good fit. So a few years after that, some cryptic advertisements in the Joe caught my attention. Tired of high pressure sales tactics from your irrigation activation companies? Yes. Then a few months later, introducing the EdgePRO laser. But of course, that new toy conversation popped up in my head again. So I called Chris Bailey, our Edge rep, and he stated some pretty interesting things. So Edge didn't really even need to apply for any new patents because the technology was based on the original BioLace tool, but had the hard tissue cutting capabilities removed. They decreased the power from a 4-watt to a 2-watt laser and was like less than half the price. Green light. This was a way to have the latest, greatest technology without the new toy phenomenon. So I hounded Chris for a few months, and the first week it was available, we purchased one. Now, sometime later at the Phoenix AAE, I was taking advantage of an AAE discount and purchasing another EdgePRO for our second office when an endodontist noticed and asked me about my purchase. I said, actually, I'm purchasing my second one. And this started a dialogue that, more endodontists in the booth became engaged in. And my friends from the Navy who currently run the endo department, shout out to Nancy and Susan, were mildly interested in having me come and speak to the residents about the device and just utilizing these technologies. And I left the meeting with a real sense of professional reward. And so when Chris approached me a few months back about sharing my story with you all, I said, sign me up. So now that I've kind of gone through my story, I want to kind of go through the basic protocol that I've sort of fallen into that I use basically on every case. It's kind of the 80-20 rule. You use it 80% of the time, and then 20% of the time you have the interesting cases that make us fun, the ones that you write stories about. So first of all, I want to emphasize you want to clean and shape as normal. That's one of the things that Edge pushes. It's like, we don't have to change anything. You just use this as part of your system towards the end or along the way. And I would strongly encourage you to follow that. I kind of got into a situation where I tried to change so many things at once that my operations became a little bit unpredictable. And I kind of had to back up and start using my protocol again and slowly make changes along the way. So basically, my protocol is 3 different steps. I've got the mid-root protocol where I use sodium hypochlorite, 5 millimeters from the apex, and the long, thin tip, which is tip 3, I believe. And then I rinse with the EDTA for the smear layer removal, rinse out the sodium. We actually use citric acid in our office just because it's exponentially cheaper and does the same thing. But basically, it's funny, when I made this slide, it says no EdgePRO. Like in the last week or two, I've actually started using the Edge because you're already in the mid-root protocol and it works the same for the sodium as it does for the citric acid. So I do actually do that. That's kind of the fun of this. I slowly progress and change over time with things. But and then the apical protocol, you actually turn the laser up a little bit, and all these settings are in there. I'm going to show you how to use these. But you take the tip 1 millimeter from the apex and use sterile saline. And I like the 5-second withdrawal. You'll hear that a lot. That's kind of the standard way to do most of these things. Do these, place the sealer, all this. So when you go into the system here, the hybrid technique, you click on the hybrid technique button, takes you to this screen. And I start with the bottom left one, the sodium, it says solutions in sodium hypochlorite. Tip 1, the recommended one, is the one that I use. And then we get to this screen here, and you'll see it's 15 millijoules and at 50 hertz, which is basically the pulses per minute. So you do the same, I do each canal, like I was talking about, 5-second withdrawal, 5 millimeters from the apex, each canal. Place the EDTA, same thing, and then go to my apical protocol, which is water. And you'll notice it's 25 millijoules. It's actually increased power. And you'll also notice that in the middle of the screen, there's a little wind symbol that says 20%, that's the air, and then the water symbol is 20% as well. So because it's water, you do want to be pushing the air in the water so you can kind of refill it, because with this extra power, you're going to get a little bit of that splashback, which you'll have suction there for and everything. And again, it's sterile saline, so it doesn't hurt anything. But this is really, I feel, the one that opens up that apices and gets into those really complex apical ramifications. A quick tip I would like to really point out, I didn't actually know about this until about 3 weeks ago. In the bottom right-hand corner of most of the screens on the EdgePRO, you'll see this little like heart tooth. And if you click on that, you can actually set a setting and name it whatever you want. So Dr. Horsebill, Dr. Thompson, me, my Apex one. And so this heart symbol is actually on the home screen, and you can touch the one you want, and it's only 2 steps. You don't have to pick the tip. So it's a little bit streamlined for you, and it's a way to kind of increase efficiency once you know exactly what you want to be doing. So that's the protocol that I use on basically every single case. Now time to talk about those 20% of the cases, right? Always start with the standard protocols, say that more than once here. Once you're comfortable, you get to customize this. And I'm gonna show you how to do that. And I'll never forget, one of my friends is an orthodontist. We were talking one day and he gave me this quote, treating everyone the same isn't specialized dentistry. And I was like, that's a great line. That's got so many applications in our profession, periodontists, orthodontists. So sometimes the teeth don't study the anatomy books, okay? So I had this case come in, I want to say about 3 or 4 months ago at this point. And I noticed, in my PA, the apex looks atypical, we'll say. So I went ahead and got the cone beam, and this is a slice on the right here. The apex is literally a circle all the way around, starts as 1 and becomes a circle. And you'll notice there's a little shadow in the middle on that left PA. There's actually bone in the middle. It's truly like a donut shape. I don't know, we'll call it circular because I don't know that there's a name for this. So there's cases that are just not going to follow these standard protocols, right? So what you can do on all the screens, there's this gold arrow right at the top of the screen there. If you click on that, you can get into the brains of the operation here, and you can basically change any setting that you want to. Now, the nice thing is it's only the top 4 that you're really going to want to change. The millijoules on the upper left goes from basically 5, I think, all the way up to 50, or 75 actually. And the pulses per second on the right is basically the frequency that you're firing. So if you turn it down, you hear that instead of the, you can just kind of hear the rhythm of it. These auto buttons are applying to the air in the middle left and the middle right here, and the middle right is water. I would just absolutely always leave those on auto, because what that means is when you push the pedal to, when you're on ready mode and it's green on the bottom of your screen, you are going to get water, laser fire, and air out of them. There's an on that I did not know you could change and changed by accident once. Basically, every time you push this button and it's on green, the thing is shooting water or air at you. So, you'll learn, it's over here in the holster and there's water going everywhere, and like, well, what's going on? So just leave those on auto. You don't have to change that. When I have bleach in the canal, I don't like to use air and water, and that's just, again, the standard protocol that Edge recommends as well. The bottom 2 things are kind of superfluous. The bottom left is aiming. That's just the little red laser that you see when the Edge is ready to fire and the button is, the pedal is live. Rheostat. I think it's just technically it's just a pedal because it's not a rheostat, but that it can get brighter and less bright. That's what the aiming is. So that's kind of just a visual cue that you're ready to go. The illumination is purely just the headlamp at the end of the piece, which I usually just leave off because I have enough illumination with my microscope, I feel. So so that's, basically you can get in and do anything you want to. And again, anywhere along the way here, just save the settings and you can set up, hey, I want to use this setting. I found it works best in this situation. So kind of getting back to the circular apical third tooth, just getting into the case a little bit. I elected, there's one on, it's the palatal aspect there. There's sort of one true canal and the rest is this sort of uniform C, but it is a uniform open canal most of the way up and down, which is interesting. Most of these, C-shaped canal systems are not that way. They'll have a fold and it'll be a little harder to get into. So I elected to actually, because the dentin is actually pretty robust here, I actually machined 4 canals, mesial, distal, the palatal was already there, and then the facial, up to about a 2504. And then utilized everything. I mean, I threw the kitchen sink at this tooth, clearly, this is a calcium hydroxide tooth, this is a, I used the chamber mode with the 75, power laser mode to just get into all the top ramifications, and use the middle third mode, the apical third mode. And, I ended up with a pretty decent result, I think. You can see on the right there, I would say, it's arguably I'm a little long at that palatal aspect there, but normally I would pull that. But in a case like this, I'm like, I'll take what I can get. Patient was asymptomatic, got a really nice fill, this little webs in between, and you can actually see the apical, the mesial, the distal, and then if you look real close, even the buccal, like actual machining that I did to get to the apex on this. Really fun case. I don't think I would have been able to get this result without the Edge, you know. And again, I use calcium hydroxide a lot less with EdgePRO, but there's definitely a time and a place for calcium hydroxide. So patient was asymptomatic, and this was only a few months ago, so I don't have any follow-ups on it. But so now we've talked about the cleaning and the shaping. So once you have this tooth cleaned out, how do you obturate, or how do you get into all these things you've opened up? And I would like to talk to you a little bit about the tips and tricks that I picked up along the way. Two main things that have really changed the game for me are something called microsuction, which is something I kind of came up with on my own. It's not the little medical surgical suction. It's actually, I'll show you here in a minute. It's great for drying the canal. It's great for pulling out loose things that are just floating around in the chamber, you know, and you're not just picking at it with an explorer for 3 minutes trying to roll it out of there, or ultrasonic in it, hoping it shoots the right direction. But then I want to go through also my obturation technique, because sealer placement is really important here. And I'll go through the single technique, the single cone technique that I've picked up as well. So this is the microsuction. And I just want to kind of take a side here too. I ask the Edge guys, hey, I know you guys, this isn't something that you guys are selling, but is it okay if I kind of promote this as something that's really helped me in my practice? And they're like, oh no, absolutely, but we want to know about you. It's your story. And this is, I mean, can you imagine getting that from any other company? So shout out to them. I really appreciate this. This is not their equipment, but again, these are just really simple, inexpensive, basically oral surgical tips that most of us just have right there, that we normally have on there for suctioning away irritants and any kind of saliva buildup that might be happening. And you simply put this tip, which is a 0.48 millimeter ultra dense capillary tip. It fits right on the end of this, and when the suction is on, it's like a thunk. It just fits on there amazingly. And you can take that plastic and roll it around about 180 degrees, let go of it, and you have this like little nice 90-degree curve in there. And you can just rotate that around, and that pre-curvature allows you to get into these distal aspects of second molars. And there is this old tool, I was trying to think of the name of it. It is the Endovac, maybe? Way back, right? One of the very first of these kind of tools that we've had at our disposal, and you just look like a spider and all these tubes coming out and everything. But the basic principle was you would take these irrigation tips, the suction, and put it down at the apex of the tooth, and then place your irrigants up at the top, because of the way the thing was designed, and it would pull the irrigant down and pull it back up. Well, basically think of that exact process, but with air. So when you put this in a canal, it dries the entire chamber because you're pulling air all along the whole thing. And it's a great way to dry out your chamber prior to using your cotton points or paper points in preparation for placing calcium or obturating the case. So I have loved this, and because it has that suction tip, you have those little round stones that are the square peg round hole situation. You got your small access that we're all super excited about, but then you can't get these stones out. You can actually put this right on top, and it just thunk, and you can just pull it. It's like playing a game of Operation. You remember that game from a kid? It just comes right out. Sometimes you pop it off and you put it back in there. But also separated files, the ones where you're going into the canal and you catch like an isthmus and don't quite get into the canal, and just the 2 millimeters of the tip is laying in the pulp chamber, like dangerously close to getting in the big canal and causing you a lot of time and frustration. This is awesome for that. You just go right down on top of it. It just snags it, and you just pull it right out. You don't have to go grab. It's just, it uses that vortex or that vacuum to pull it out of there. So would really encourage you guys to play with this, see if you like it. It's really been a game changer for me. But let's move on to obturation. So obturation, doc, we have the canals totally cleaned out. We have these really nice lateral canals all really open and ready to go. How do we get our sealer in there? So I would recommend, and it's interesting, I picked this up. I was kind of thinking this way already, but I picked it up mainly at the Phoenix AAE. it was really cool to see how things had changed after COVID, because that was kind of the first live conference that we'd had as the AAE. But basically, my recommendation is we place a high flow sealer prior to putting the gutta percha into the canal system, and I'll show you how I do that. And then slowly place each gutta percha point like 5 seconds again, slowly. So you're just pushing that sealer ahead and into all the three-dimensional ramifications and lateral canals and isthmuses that you've just cleaned out with the EdgePRO. And I'm going to show you the techniques that I use to use that in the tools. This is an amazing tip. It's hard to say that about the tip of a sealer thing, but hear me out. First of all, the reservoir is very small. So you're actually going to be saving quite a bit of waste, because the tip, is narrower, or the reservoir is narrower. So this liquid gold, is what my assistants call it, BC sealers that are like $100 a tube, you're not wasting nearly as much of that. So that pays for the tip by itself. So even if you're only using it for that reason, that's great. But if you'll notice this brown tip at the end here, it kind of looks like it's copper. It's actually a plastic material. And it has a similar, I was trying to find an analogy. The plastic that comes around flowers, you can kind of crinkle it down and it goes and just pops back up. It has that property to it, that's shape memory, or if you want, if you can call that with plastic. But basically, you push it into a canal and you catch an isthmus and it wads up on you, you can just pull it right back out and it just pops back out and it's ready to go again. But it allows you to get around corners, and you can get right down to the apical third, usually, depending on obviously how open the case is and how curvy it is and what you're trying to achieve there. But routinely, 80% of the time at least, you're getting down to that apical third of this. So the way I place this is I put my BC sealer in there, the high flow stuff, and then I place the tip until it just binds. Now, it doesn't bind like a file, but you can kind of feel it stop, and you're bouncing a little bit. Pull it back about 1 millimeter and start pushing in your sealer, and slowly, again, 5-second withdrawal, slowly, and you're looking at this with your microscope probably, right? So you're watching it pull back, and you stop when you're about 2 millimeters short of your opening, your canal opening. What that allows you to do is, the path of least resistance for these sealers as you're placing it is to come up. But there's a point where you've engaged enough and there's enough of it in front of it that it stops flowing back up into the chamber and starts going down into the canal. So don't fill these up to the brim. It's like filling up the bath water and then getting in and wonder why it overflows, right? So it's going to come up a little bit. So it's great material because it's water soluble, and you can just, once the canals are obturated, you can just blast it out with water and this little scrubby brush, and it comes out very, very nicely prior to etching if you're placing a core. But and then again, you just place that cone slowly into the canal and you burn it off right at the orifice. And by doing that, occasionally, like, whatever, how many, one a day or one every few days, you get a case where it's like, my working film or my obturation check film, it's a little short, it's a little long. You didn't melt it down halfway down into the canal system, right? It's right there. So you can take a headstrom, like a 20, go right down along next to it, like 3 twists, and just pull it right back out. And it has changed my obturation efficiency at least by 50%. I mean, I'm extremely happy with this single cone technique. So now that we've talked about that, let's talk about what you end up getting, right? These are all my cases that I did personally. My partners gave me some cases too. I had like 10 or 15 of these, and it was just going to be this like running slideshow of all these just gorgeous cases. But no, scratch my own back, right? But cases that I wasn't able to really get into much without an EdgePRO and all these little ramifications. But I wanted to, again, we all practice differently in the practice. I'm not 100% sure how they utilize it. I started asking them, and it's kind of, there's all sorts of ways to do this. That's, again, they're just utilizing it in their preferred technique, how they want to do it. But I want to highlight a couple of things here. If you look at this incisor in this lower central area here, this is why I use the EdgePRO on every case. I didn't see these lateral, especially didn't see that apical lateral canal. If you look and closely and you squint and you really want to, you probably could have seen that bigger one in the middle there, but that little more apical one, that wouldn't have shown up on a cone beam. And if that's all there was, it might have shown up on a cone beam. Again, there's different cone beams and the whole thing. But my point is, you're not worried about only using this on the complicated cases, right? It's a single canal anterior that actually has a canal, right? But you can get this kind of thing unexpectedly sometimes just simply by using this protocol and power washing out the tooth. I say that with patients sometimes just so they have a understanding, but I like analogies if you can't tell. So I also want to point out, the upper right case, these little apical ramifications. This upper left case was, so on the cone beam, this was actually a C-shaped, it was one canal up top and then became C-shaped mid-root and got down to the apex there. And that, again, calcium case. Patient was completely asymptomatic, and I obturated it and got these little lateral canals and all of these little fins where everything comes together. And, it's really rewarding. And like it or not, unfortunately, as endodontists, this is what we're rated on, right? If you send something to a general dentist and you're clearly showing them that this is what you can achieve as an endodontist, that is at least good marketing, but at most professionally rewarding, right? To be able to show them a case that there's no way they maybe could have done. All these apical splits in this lower right case, I didn't know those were there. I mean, I could, in a cone beam, you could see, well, there's some complexity down there, but knowing that you were going to get these nice splits and these nice little sealer puffs. So I'm going to go through this bottom left case specifically because this is a really interesting take on what I like to call getting a mechanical patency instead of using a file to do it. It's probably the wrong word, maybe energetic patency. So I could tell on the CBCT, this is, mid-root here, there's a split where MB2 is separating away from MB1. And during the case, I tried to get into that, pre-curved my file, kind of pushed it in that area, got around, and I did get into it maybe a millimeter or two, but it just kind of stopped and didn't really go many places. So I was like, you know what? I'm just going to go ahead and obturate this case today after I utilize the EdgePRO. So I knew where that ramification was. I measured on the EdgePRO, measured on my cone beam, and put the laser right there and went back and forth, only firing as I'm pulling out. 6 or 7 times in that area with citric acid, with the sodium hypochlorite, powered it up, went to the apex with water. And, you end up with, what I want to point out specifically is the distal canal. I know I was talking about the mesial buccal, but we get in situations sometimes where we have what we call in our practice a hard stop, where it's about the right length, but you're just not gaining anything, and you bend small files and you're just not really getting anywhere. Well, when you take this down, you can see what happened there. I have almost a 90 degree, I'd say maybe 70, 80 degree curvature down there. I was able to get into with the EdgePRO laser, utilizing the water at the apex. And, I didn't know that's what it was going to do, but after I obturated using this technique to push it 3-dimensionally down in there, you end up with results like this. And that lateral canal and the palatal is just gorgeous. But just focusing here on that bottom left image where you can kind of see the different angle, and that's where I did get into that MB2. And patient's asymptomatic, called them the next day, everything was great. And then again, this was last week that I did this case. So just kind of threw it into the lecture here in the last minute, and then this bottom right is just to kind of zoom in where you can see that separation for that MB2. So that's basically the end of my lecture here. In conclusion, I want to kind of go through a few things that basically kind of put everything in a nutshell for you. I love the EdgePRO because it's minimally invasive to your workflow. And I can't stress enough, I would encourage you to not change anything other than this irrigation system before you use this. And what you'll find, just like I found with that case a few days ago, and I knew I had that one zone in there and I really wanted to kind of go in there and power wash it out, or that circular apex case where I was using the chamber mode, this EdgePRO is going to become like a workhorse for you. You're just going to find new ways to use it. You're going to start preconditioning with it. In our practice, the reason I do on every case the last 2 is because I can get to those. I get the machine in my operatory, and once I have my working length film, just talking about the logistics of how I use this, we have a in-office buzz system on the computer there, and my assistant turns around and knows to buzz for the EdgePRO, and by the time I have working length and I take everything up to my master apical file, the EdgePRO is sitting there ready to use. I reach over and I use it. So I'm not waiting on anything. You just find the pace and you use it in your system there. And I've been very happy with how that's worked. And this is another thing I'd like to talk about. The machine is pretty robust. We have only one per office still, and we often have 3 doctors, you know, in the one office. So seeing an average of 5 or 6 cases a day, utilizing this each, you know, we've got 3 docs, 15 cases, you know, maybe 18 cases in a day. We're powering this thing off, rolling it down the hall, powering it on, purging it. And we've been doing that for years. So, you know, this is, the workmanship is good. I do want to mention one problem that we had that you can easily circumvent by not trying to save money. As endodontists, we like to be thrifty. You know, we like to have our overhead just be as narrow as it possibly can be, or as tight as it can be, I guess. We tried to reuse our tips, and you know, we'll just reuse them once, because then it goes from $20 a tip to $10 a tip. It's just a file, you know. What we found after about a month of that was we started having power output issues. So when you set the machine, it wouldn't give you the same vigorousness you were used to. And we started having technical issues. We bring the reps in, the mirrors started getting a little pocked. So it's not worth that, because the cord is like several $1000s, because it's, you know, this fiber optic cord. You don't want to be messing with that. The mirror is not cheap either. I think it's solid gold. Chris can give you it's priced like it's gold. So you don't want to throw the baby out with the bathwater here. So don't use the tips more than once. Just take it from me, learn from my mistake, our mistake. I'll put that on the partners as well. We were all trying to do that. So it works well in our multi-doctor practice. And as a single doctor, I can only imagine, you know, you've got this thing sitting there the whole time. Maybe you're wheeling it over each case. You've got a couple of ops going, or maybe 3. And so, you know, you could just basically have it there to use anytime you want. I think you're gonna, if it's sitting there, you're gonna use it more often. But I'm gonna go back to Dr. Gearing, and I'm gonna give you an opinion now. If you can only take one thing away from my lecture, it would be this: electronic irrigation activation is here to stay. It was really interesting in Phoenix when I was there, looking at the change where, you know, prior to COVID, it was, is this something that we need? Is this something that helps? Is there any statistical differences? Are there any outcome studies, right? It had gone from that to, how do you operate these cases the best way now that you're utilizing these technologies? So I'm gonna go out on a limb, and I'm gonna say a bold statement. I think the EdgePRO will do to irrigation what CBCT did to radiology. I think it's that big a jump. And I can't imagine working without a cone beam. I know a lot of you that do are the same way, right? I mean, I would never treat a molar anymore without a cone beam. So just as a fun tip, fun little last thing here, as I was downloading these programs I needed for all of this online webinar stuff, this is not something I do very often, but I ran across this free AI generated thing. So I just put in futuristic laser root canal. You can see the limits of artificial intelligence a little bit here. I especially like the upper left one, the person that's doing the root canal on themselves. Very exciting, with a gun. Upper right, you know, you've got, we're melting the metal tooth that's coming out of the upper molar there. A little transposition of a central and a lateral in that lower left area, and that molar is really popping out too, that we're shooting at from across the room there. But anyway, I thought that was a really fun exercise, and I just wanted to share that with everybody too. So yeah, thanks for coming. I appreciate it. I'll go give it back to Chris and open it up for questions.
Great. Thanks so much, Dr. Ross. It was a great, very authentic presentation, and certainly it's really great to see that you and your partners have been able to integrate this technology so meaningfully in your practice, and really liked how you went over some of your obturation techniques. And by the way, it really shows how thorough you are in your obturations. The dense 3-dimensional fills we were seeing in those cases looked really nice. So really great cases to share. So yeah, we do have a couple questions for you. I guess first, starting off here, there's one question around, like, let's see here. You've developed some advanced techniques over time. Was there any initial concern about whether this technology would slow you down when you first started?
Of course. I mean, anything, right? I used to have this statement that I would say to any rep that came into my office: is it better or is it faster? Because if it's not one of those two things, I'm not interested. You know, I mean, like that was my big concern. You know, I'm in a large practice. I enjoy being efficient, and absolutely, you know, it's going to be just like anything else you bring into your practice. It is going to be a learning curve, and you know and that's why I'm saying don't change anything else. Keep everything exactly the same. Bring this in and try to get a rhythm of just using this with your standard technique. You know, my standard technique, like they talk about on boards, whatever that means, right? But when you're cleaning the tooth out, you're doing everything the same. I would say I'm adding an average of maybe 3 minutes, maybe. And you know, not really probably even that much now that I've gotten the steps down to ordering the machine, having the assistant roll it down, setting it up and all that while I'm still working and not waiting on it. You know, at first you're like, all right, now we're ready to go. And then it's like, oh, now I got to set it all up. And that does take some time. So yeah, there's definitely some workflow things that you'll need to work on. But yeah, it's just like anything else. You work the cone beam into your practice probably. You know, it's going to be something that once you utilize it, you know, it's kind of one of these interesting things that I would hate to not use it. You know, we do a Colorado Mission of Mercy every year, and I was joking, we should bring EdgePRO to that and just have it there as a talking piece, you know. But it's something that you'll want to use on every case. And like if something's like it's down the hall and you can't use it for some reason, somebody's really you know got a super tooth and they're in there with it the whole time, and you end up in a situation where you don't want to use it. You know, you kind of like, do I want to obturate? You know, so the short answer is yes, those are all going to be there. But once you get the rhythm of it and it just becomes part of your practice, it won't add much time.
Right. Can you share any feedback from patients regarding post-op pain or those flare-ups or those cases where they're just kind of tapping their tooth? Any instances?
You know, that's interesting. I almost put that in my lecture because I have no data to back this up. This is a non-scientific statement. You know, it's purely empirical, but it feels like that happens less often. I mean, it's hard to say more than that. And you know, these things happen in waves. This last couple of, you know, like last week, I had a couple that did have some post-operative sensitivity afterwards, and so it definitely doesn't increase it. If you look at, if I'm not mistaken, if you look at the literature, well, okay, in my experience, we'll say, the cases that you have the most post-operative sensitivity are going to be vital, and they're going to be cases with complex anatomy, apically especially. So we're talking lower molars, right? If anybody comes in and they're doing the tooth tap, doc, I don't know, just every time I tap here, you know, that thing that drives all of us crazy, drives the patients crazy. When they're doing that, it's always a lower vital tooth. I mean, or an upper vital tooth potentially that has fused palatal to mesial buccal, palatal to distal, all fused, you know, these isthmuses that we're not able to machine adequately. And in those cases specifically, the EdgePRO is great because you can put it in, you know, you can bust out the whole top zone and kind of see where the canal is with the chamber mode section or setting. And then when you utilize it internally and you're done and you look, you don't have that, you know, schmutz in the canal system anymore that you just could look in there and just see. That's all gone. I mean, you can see it coming up. One thing, and this is totally aside, but one thing that if you ever get this and you start using it, or if you already have it, go through and do a retreatment and clean it out as good as you possibly can, like everything that you've ever been taught. And as a very last step, go in with the EdgePRO. I guarantee you'll see pink giblets coming up that you just weren't able to get to, you weren't able to engage with. And if that doesn't tell you that you're getting it clean, or nothing does.
That's great. What has been your experience with hyperemic teeth? Have you been able to decompress the area to complete treatment in those instances?
That's a big, that's a lot to unpack. So hyperemic teeth have multiple, obviously, etiologies. if we're talking about accessing and just having the welling of blood, you know, that's that first, that absolutely, you can go after, I've done this, you know, you don't need irrigant because there's plenty of blood in there. So you go in with the EdgePRO and use the chamber setting with the short, that's the tip 1, right? Or tip 3? Tip 3, thank you. The short fat tip, the tip 3, you put it on 75 and get the suction ready because this is it's going everywhere. But you get the suction in there and you just basically fry that tissue, and it does a really good job of slowing that heme down in that specific instance. Now, careful, you know, things bleed for different reasons, right? If you might have been a little long, you're a little close to the inferior alveolar nerve, potentially / artery, there's a lot of pressure down there, right? I have had cases when I'm close to that and I use this and I start to have that little heme coming up from that. The best way I've found to stop that is hydrogen peroxide and a paper point. You dry it out with my microsuction. I use that for these types of things too. Now you don't want to hub it if it's bleeding. If you put the microsuction in there, you're just going to be wicking it. You know, it's just going to continuously bleed. You're never going to get that clot. So dry it out, but don't hub it. And then take it out, 2 dry paper points. And then if you put hydrogen peroxide on the apical third of a paper point and just put it in there and leave it alone. Don't look at it. Go take a drink of coffee. Leave it in there for like a minute. It's what you're doing is you're compressing it. And then the hydrogen peroxide is doing what hydrogen peroxide does on our wounds and is cauterizing it, and it'll cauterize those vessels, and you'll be able to obturate those cases probably. But yeah, be careful with if you're really close to some, you know, the inferior alveolar arteries specifically. I would hesitate to go in there and try to power wash things out with the laser at the apex. Another case I had, I want to say 2 weeks ago, was really interesting. The middle foramen, the middle nerve came right up. So if this is it literally came up the side of the tooth and exited. I did use the edge on that one, but I didn't use the apical mode. I didn't want to get into that because you're just asking for trouble. There's a lot, I mean, the nerve was literally right there. And that's why I get cone beams on all of my lower premolars. I just really need to know where that middle foramen is. So yeah, there's definitely cases where you want to be careful and diligent, but yeah, as long as you know why it's bleeding, you didn't perfect, you know, things happen. Then there's definitely, specifically when you access and you get that hyperemia, the edge is great for just getting rid of that tissue out of there and slowing that down.
Yeah, and in those cases, you are going to get some bleeding. And there was a follow-on question to that. Any tips to prevent bleeding after laser-assisted irrigation? I would assume along the same lines of what you just mentioned, right?
Yes, yeah. Don't use sodium hypochlorite at the apex. I mean, you'll notice that if you just use the settings inside the EdgePRO, that's at 25 megahertz. It's higher than the 15. You're also pushing air and pushing water. So you're just kind of asking for a problem if you actively use that one tip and go all the way to the apex. So that's why I use the sterile saline. You know, you're pushing water and air, and water's already in there. If you get a little bleeding, it's not because you have an accident. You know, it's because you're actively engaging inflamed apical tissue, and that's starting to bleed a little bit. So in those situations, I've never had it bleed very much. And if it does, you know, some of these other devices that are out there, you see these, they take it off and it's just like, you know, I mean, you don't get that. That doesn't happen. So it's definitely not something I've had a major issue with. And the peroxide trick is really golden. I mean, it's helped me obturate. It's been a long time since I haven't obturated a case because it's hyperemic.
Yeah, great. Yeah, another question around, you know, many are using the EdgePRO in addition for advanced cleaning and disinfection to help with patency, recapitulation, blocked out from calcium. Do you or your colleagues use the EdgePRO in that application?
Go through those lists again real quick.
For helping to achieve patency or with recapitulation?
So I think our terminology is going to change as we start using this. I was running into that problem myself. Like, what am I calling this? You know, I don't have to stick a 10 file at the end of the tooth anymore to get patency, you know, like we used to. Basically every case, you know, my protocol is going to the apex with the sterile saline. That is absolutely creating patency, because that's why I'm getting, you know, if we go back, I don't know if you're still looking at my screen, but that's why we're getting all these little nubs and things at the apex, because we're creating that patency. You know, I didn't stick a 10 file out there. I couldn't have gotten around that 45-degree bend, right? Or that 80-degree bend.
Yeah.
But you know, you're just pushing irrigant around down there, and irrigant meaning sterile saline. It's just in there power washing it, you know, just really getting into all the 3-dimensional ramifications. I would argue that every time I use the EdgePRO, I'm doing that.
Okay.
And I think there was a question about calcium hydroxide too. Yes, if is it absolutely worth getting the edge set up in my practice to get calcium hydroxide out? No, probably not. In a complicated case where I'm really wanting to try to get all of this, which, you know, at some point, you know, if it's a single canal anterior, yeah, it's probably fine one way or the other. But yeah, the edge is great for that. You know, you go right to the end of the root and it'll just push. It'll push it out in like these big chunks. You know, it'll come right on out. And then you can go in, especially with a acidic, so your chelator, whatever, so citric acid, EDTA, and it'll really help peel it off the walls there, and you're just powering it in, and yeah, it'll be cleaner than, it'll be a lot faster. You know, I would argue that calcium hydroxide is fairly easy to get out most of the time, unless, you know, there's definitely exceptions to everything. But yeah, the edge is great for that because your canal's wide open and you spin it all the way to the tip. I would get most of it out first because otherwise it's going to go everywhere. So just like maybe go MAF with some irrigant of some kind in there, either a EDTA or even sodium, honestly, and just get the bulk of it out of there and then go in with the edge, because, you know, you're kind of fine tuning it with the edge and just getting all the little pieces out instead of blasting, you know, all the sodium up out of there. And when I say blasting, it's not like it's shooting across the room, but I mean, you can see it jumping out of the tube. So I get exuberant when I talk about with patients and stuff, they like that. So.
Well, this is great, and great questions. I guess we'll just kind of finalize with one here, and you've deeply adopted this technology, and it sounds like every case, every day, you and your associates. If you're a clinician that's been following EdgePRO and contemplating on whether this technology is right for their practice, what would you say to them?
Based on my own experience, I mean, my obvious answer is yeah. I would seriously consider adopting it. You know, the price point is reasonable. I'm very happy with the cases I'm getting. The general dentist mentioned it to me. I mean, it's this internal marketing thing. It makes me feel good to come to work. You know, like I feel like I can play around with these teeth and get really, really awesome results and really feel professionally rewarded, like I did at the end of that meeting, by doing these things. So, you know, I kind of think there's like 3 kind of groups of people that might be looking at getting an EdgePRO like this. You know, there's kind of the entry level, coming right out of school, looking to see what kind of technologies they want to get in the new practice they're establishing. There's kind of like me, the middle of the road kind of, you know, you're kind of stuck in your rut and you're doing your thing and you're kind of like trying to figure out how to be excited about going to work again. And then there's the kind of twilighting doctors that are kind of going towards looking at a way to increase the value of their practice and utilize a technology that might bring in a potential buyer. Anywhere along the whole chain of an endodontist career, there's so much value to this. I mean, it really is. And I hate to, I'm not usually super all in on something, but you know, it's kind of like the cone beam. When I started using the cone beam, I started using it on cases that I was having problems with. And I started noticing these complications and these, you know, fusions of roots that I didn't know were there, and apical splits and all these random things we just, you know, you read about, but you never see. And I just had this epiphany, you know, and that's just like the first year of my practice. When I came here, there was a cone beam in the practice and I never used one before. So I just was trying to figure out how to utilize it, right? And the senior doctors didn't really utilize it. They kind of had bought it to get new doctors in and, you know, be high tech and all that. So, I mean, they utilized it some, obviously, but so basically, I had this epiphany. I started using it always before when I'm doing a molar. And, you know, I've never taken a cone beam and been upset that I took one. I've often taken one and been really surprised, right? It's like, whoa, okay, interesting. And even if it's a really simple anatomy, you know it's a simple anatomy, so you don't have to dig for MB2. You know it's not there, you know, even though it's there most of the time, it's 100% not there now. You know, that just tells you that, right? So that's kind of like how the Edge is. You know, you start using it and you start getting these results, and you start not having to open cases up as much, and you start just getting these really interesting anatomies, and you just start utilizing it more and more as you have it. So would I get it? You know, yes, I mean, absolutely. I mean, I guess it's a short answer, but I've been very happy with it. My partners have been very happy with it, and you know, I've been extremely happy with the results I've achieved with it, basically.
Great. Well, great. Well, that was the end of the questions there. I appreciate, again, you joining us, Dr. Rosh, and sharing your experience. Really insightful. And for those that have other questions around, you know, the mechanism of action around YSGG and the wavelength that EdgePRO utilizes, which is erbium chromium YSGG, certainly all those questions can be answered. We've had other webinars that have gone through that, but we have our area sales management team that can walk you through the technology in a more in-depth fashion, give you a test drive, let you play with it, understand the user interface and the settings, some of the settings that Dr. Ross walked through tonight. Just leave you on that note. I think that's one thing that when we were looking at partnering with BioLace and developing this technology, we knew that YSGG had been proven in endodontics. There's been data back to the early 2013 or so around how this wavelength that's attracted to water and hydroxyapatite is able to precondition biofilm and remove smear link just with water. We know this. A lot of studies been done on that. So now, you know, you fast forward, we've tried to build EdgePRO into a form factor that's ideal for endodontics, certainly appropriate, as you've seen tonight, for advanced cleaning and disinfection, which is kind of the marquee application. But we're finding there's so many adjunctive benefits too around helping to achieve patency, so your files drop down a lot easier, being able to block through you know, calcified situations. So it becomes, as even as Dr. Ross mentioned, a real workhorse tool. It's a tool that you're going to pick up throughout the case and just kind of fits within your workflow. So that's been, you know, with the close to 600 clinicians now that have come on board since, you know, early to mid 2022. That's been kind of the overwhelming feedback, is it's been used for so much more. It's become a workhorse tool, easy to use, easy to fit within your current procedure, and then hopefully at a price point too that is palpable and can be something that you can adopt meaningfully, as in every case. There's no such thing, as we've heard, as a non-laser case. That is just, you know, what we're hearing from our user base, and certainly sounds like corroborated by Dr. Ross tonight. So as you have more questions, please reach out to your area sales manager. We do appreciate you again, Dr. Ross, sharing your great experience. And thank you, everybody, for sharing your time with us this evening. We'll go ahead and sign off. Wish everybody a very happy and healthy Thanksgiving, and we'll look forward to speaking with everybody soon. Thank you. Good night.
Thank you, Chris.
Thank you.